Excuse me. Excuse me. I'll be speaking.
Shilpa, we can start. Good morning and warm welcome to Online Anesthesia, an anesthesia update in Zoom platform sponsored by Akrula and hosted by A1Logist, and our media partner is Anesthesia TV. Today we are having two interesting topics. The topics related to cardiac patients coming for non-cardiac surgeries. The first topic is perioperative management of patients with coronary stents by Dr. INDRANI HEMANTKUMAR. And the second topic is the pacemaker and its anesthetic implication, what an anesthetist should know, by Dr. BALAJI, ASEGAONKAR. And today's session is moderated by our own colleague, Dr. SIVAPRASATH. He is a cardiac anesthetist working in Institute of Anaesthesiology, Madurai Medical College. Over to you, sir.
Thank you, sir. Good morning, all. Welcome to our online anesthesia consultant updates. Today, we have two very important topics. Both are very important for practice in the sense most of the patients we see now have some sort of cardiac intervention. It could be either in the form of a stent or a cardiac drug or a cardiac pacemaker. So we get a lot of patients and we should know how to assess them for the perioperative care and postoperative, how to manage them. So to address all these issues, we have two eminent speakers today, Dr. INDRANI HEMANTKUMAR and BALAJI ASEGAONKAR, sir. I welcome both the speakers to our online anesthesia forum. Welcome, ma'am. Welcome, sir. The first topic will be about the perioperative management of patients coming with coronary stents. To deliver that lecture, we have INDRANI HEMANTKUMAR ma'am today. I'll just introduce her. She has started her career with rocket speed. Like she has got first rank in her MD and DA from her in Mumbai University, following which she has got her Hargobind fellowship to get trained in cardiac anesthesia at Lehigh Valley Hospital at Pennsylvania. She has headed the SEGS and KM Hospital and Medical College for so many years, and now she's retired. She is now the honorary professor there, heading the Pediatric Anesthesia department. To her credit, she has got a lot of workshops, simulation trainings, and she is the founder of the famous masterclass for postgraduates. She has been the president of Society of Anesthesia and Clinical Pharmacology, and she's also been the governing council member of the Maharashtra State ISA. A warm welcome to you, ma'am. We are eagerly waiting to hear your lecture. Over to you, ma'am.
Good morning, everybody. At the outset, let me thank Professor Edward John and his entire team for giving me this opportunity to talk on this very important subject on perioperative management of patients with coronary stents presenting for non-cardiac surgery. And let me start by just sharing the screen. Okay, I think it's clear.
Yes, ma'am.
Okay, fine. Well, there is an upward spiral in the number of patients with coronary stents presenting for non-cardiac surgery. And to this day, we are talking about more than 3 million people annually presenting with coronary stents for non-cardiac surgery. 90% of them receive more than one stent. And the problem with this is the anesthesiologist have to delicately balance the risks posed by antiplatelet therapy. On one hand, you have thrombosis, and on the other hand, you have bleeding posed by the stent placement. So there are majorly two types of stents. One is a bare metallic stent, and the other one is a drug-eluting stent. The stent implantation causes injury to the endothelial surface, and it initiates interactions between the stent surface, blood, and the vessel wall, leading to neointimal hyperplasia and increased thrombogenicity. Various coatings are available to prevent this complication. Sirolimus is a naturally occurring immunosuppressive cytostatic agent. Paclitaxel is anti-proliferative cytotoxic agent. We also have bioengineered stents, which are antibody-coated or even antiplatelet-coated. And of course, we have a bioabsorbable stent, which are the second-generation stents having zotolimus and everolimus. Coming to bare metallic stent, the incidence of restenosis is extremely high with VMS. The neointimal hyperplasia, including the lumen, is bound to occur, and it starts by 3 days. And it can occur up to 3 to 6 months of intervention, which means the patient can come for a repeat intervention. Endothelialization starts occurring immediately, and it occurs over a month or 6 weeks. Drug-eluting stents is composed of 3 components: the platform, which is the stent, a carrier, which is a polymer, and a drug to reduce the incidence of neointimal hyperplasia. Stent coated with substances that inhibit muscle proliferation and neointimal hyperplasia is present, of which, as I already said, sirolimus, which gets eluted within a month and leaves a bare polymer, the metallic stent. Paclitaxel elutes only 10% of the drug, and the rest remains with the polymer indefinitely. Endothelialization takes from anywhere between 6 months to 1 year to 2 years. There is no test to prove complete endothelialization, and dual antiplatelet therapy duration, can we even comment about it? So no, we don't even know how we can comment on dual antiplatelet therapy, because there are patients who come with off-label stent use in whom dual antiplatelet therapy has to go on longer. Then we have the biodegradable stents. They have different coatings and delivery systems, I told you already, including bioabsorbable material. They get absorbed by about 1.5 to 2 months. It disappears within 6 to 8 weeks, allowing reduction of antiplatelet therapy and subsequent weaning of antiplatelet therapy in the patient. And these are the patients who can safely undergo non-invasive MRI testing. So in this background, so what is the long-term safety? Acute infarctions and late mortality can occur. Restenosis may be insidious, and stent thrombosis occurs as an acute catastrophic event, especially when the patient comes for a non-cardiac surgery. So there are a few ischemic risk predictors which we have to keep in mind in all these patients, and they are broadly divided into clinical risk features and angiographic risk features. So if the patient has any of it, please remember, these are the patients who are prone to perioperative MI. So they are, one is antiplatelet therapy withdrawal, multiple previous MI, previous stent thrombosis on adequate APT, when the ejection fraction is low, less than 35%, chronic kidney disease, diabetes, and off-label use when they have used on long or multiple stents, when more than 3 are being implanted, 3 lesions treated, or total stent length is more than 60 millimeter, overlapping stents, ostial stents, small stent diameter, bifurcation lesions, extensive coronary artery disease, incomplete revascularization, or treatment of chronic total occlusion. So in all these patients, remember the APT duration has to double to more than 2 years. So to know the presence of late stent thrombosis, we have a scoring system where if the patient has had renal failure, 6 points, bifurcation lesion, 6 points, diabetes, 4 points, brachytherapy, 2.5 points, and for every 20% fall in EF, there is 0.25 points. So if the patient scores between 0 to 6, there is low risk for late stent thrombosis. 6 to 9 is medium risk, and anything more than 13 is high risk for late stent thrombosis. So what happens here? Once the stent is being placed, so there is endothelial and medial damage. There is enhanced inflammation by 3 days. There is exaggerated neointimal proliferation with endothelial regeneration within 1 to 3 months, wherein there is deposition of fibrin, platelets, neutrophils, thrombus film, and the complete stent is now covered with neointimal formation. You can see the neointimal formation over here, and you can see it over here. It's almost closing the stent within 3 months. So this is the reason why we need antiplatelet medication, because with poorly endothelialized stent or with exposed metal struts, you can have, conformational changes on the surface of the platelets with expression of prothrombotic substances, activation of glycoprotein 2B3A receptors that facilitates binding of fibrinogen to platelets, and platelet-platelet interaction and platelet-leukocyte interaction, leading to an intraluminal thrombus, vascular occlusion, ischemia, and eventually myocardial infarction. So the main reasons why the patient can have a perioperative stent thrombus is, 1, because the stent is not endothelialized, or the thrombotic state due to surgery itself, or stopping the antiplatelet medication. So let us see one by one. 1, discontinuation of antiplatelet therapy. What happens in this is there is a rebound increase in COX-1 and thromboxane 2 with loss of anti-inflammatory protection by clopidogrel, with increased thrombin and decreased fibrinolysis leading to stent thrombosis and myocardial infarction. We know that surgery incites an inflammatory response. So what happens in the perioperative period is there is an alteration in the blood constituents with increased thrombogenicity, reduced flow, and in all this in the background of an incomplete endothelialization, you are looking at a perfect recipe for a thrombus. So the platelet counts go up, rebound platelet aggregation associated is there, as I already said, increased fibrinogen up to 7th postoperative day, increased plasminogen activity inhibitor is there, impaired fibrinolysis. In all this, if the patient also has anemia, then the platelet aggregation, impaired oxygen and nitric oxide delivery capabilities all go up. So that in the surrounding of a stopped antiplatelet therapy, the patient can develop stent thrombosis. A patient with only coronary angioplasty with no stent placement can also develop perioperative MI because of an abrupt vessel collapse due to recoil and vasospasm. And if the patient has a bare metallic stent, the patient can have stent injury, scarring, complete closure with neointimal hyperplasia leading to myocardial infarction, or if the patient has a drug-eluting stent, there could be delayed endothelialization and late stent thrombosis. So how does a perioperative MI manifest? It could be silent. Patient can develop anginal symptoms, with an impending acute MI, new onset irregular rhythm, or a cardiac failure, patient can have ROLS. ECG will show up as an STEMI. Biomarkers will be kicked up, TROP-T, TROP-I. TEE is the best for early recognition. Immediately, these patients have to be taken to the cardiac cath lab, and angioplasty has to be done within 90 minutes, and you have to open up that vessel. Any facility caring for their surgical patients with coronary stents that does not have a cath lab should have a protocol in place to transfer these patients to the nearest cath lab, and they should have an association with an intervention cardiologist. So now we are looking into a very important trial called the CARP trial. And interestingly, this trial compared two groups of patients, one in whom revascularization was done, either a CABG or a percutaneous intervention in the form of, stenting, versus no revascularization before a non-cardiac surgery. And what did they find? They found that there was similar incidence of postoperative MI and 27-month survival in each group, which means the question is, should the patient undergo revascularization before a non-cardiac surgery if there is no difference? So this is the conclusion. Coronary artery revascularization neither improves long-term survival, nor does it improve short-term outcome for elective vascular surgery. Now we're coming to antiplatelet medications. What are they? The first one is acetylsalicylic acid, aspirin, and diflunisal. Aspirin binds to cyclooxygenase and impairs the thrombexane A2 and prostacyclin, a PGI2 synthesis, disrupting the platelet aggregation. Then we have the thienopyridines, clopidogrel, and prasugrel, which is a more potent and a less variability kind of a drug, and ticlopidine. Clopidogrel inhibits platelet aggregation and platelet leukocyte aggregation, and as an irreversible inhibitor of ADP receptors, P2Y12, clopidogrel prevents activation of 2B3A receptor, which can cause thrombosis. Then we have the glycoprotein 2B3A inhibitors, tirofiban, abciximab, and eptifibotype. Remember, these are the drugs which are used for bridging when the patient is taken on an emergency basis and the patient is still within the vulnerable period between the stent placement and the non-cardiac surgery. And then we have dipyridamole and non-thienopyridine like cangrelor and ticagrelor. What is very, very useful about these patients, they are ultra short-acting drugs. And no sooner you stop it, within 9 minutes or 10 minutes, platelet activity starts again without any issue. So these are the wonder drugs which are now available. I think, I've said that. So the guidelines in patients with PCI without stent, that is only angioplasty was done. You cannot do non-cardiac surgery within 10 days. It's better to delay for at least a week after the procedure. For patients with stent, earlier we used to say you delay for 6 weeks to 3 months following bare metallic stent placement. The latest guidelines talks of only 4 weeks. So wait for 4 weeks after stent placement. And in a patient with drug-eluting stent, the standard was wait for 12 months, that is 1 year. Following drug-eluting stent, the latest guidelines have said that you have to wait for at least 6 months following drug-eluting stent placement. So look at this recommendation, which is published in Circulation. Elective non-cardiac surgery should be delayed 30 days. It's a grade 1 recommendation after BMS implantation and optimally 6 months after DES implantation. In patients with DAPT after coronary stent implantation who must undergo surgical procedures that mandate the discontinuation of clopidogrel and and other analogs, it is recommended that aspirin be continued as far as possible. Okay. So if you look at the major adverse cardiac events, if you compare bare metallic stent with drug-eluting stent, within a month, you will find that the incidence of MACE is much less in a bare metallic stent, whereas that with a drug-eluting stent is like 4% even after 25 weeks. So you can see that, 18 months. So you can see that the incidence of, MACE is much higher with drug-eluting stents. So once you have a patient with a coronary stent, you need to do a proper preoperative assessment. So every single line which I say is very important. So is there an early cessation of dual antiplatelet therapy for more than 5 days? Or a short delay between the stenting and surgery? These two questions you have to ask. Coexisting renal failure, diabetes, low cardiac ejection fraction, preoperative anemia. Is it an urgent surgery? Is it a high-risk surgery? Or is there any evidence of prior brachytherapy? So is the risk of surgery low, intermediate, or high? What you call as low would be any peripheral surgeries or any endoscopies like hernioplasty, plastic surgery for incisional hernia, appendicectomy, etc. And intermediate will be splenectomy, gastrectomy, obesity surgery, rectal resection, thyroid, etc. And high will be hepatic resection, ripples, etc. So you have to know what is the planned anesthetic. Is it general with regional, or only regional? Possible complications associated with your procedures. How high is the bleeding risk? If you're putting a central line, or if you're putting giving a deep block, if you're giving a block, can it be compressible in case there is inadvertent bleeding? Other individual hemorrhagic risk factors like presence of liver or renal dysfunction, tolerance to excessive bleeding means whether the patient is having any anemia, is the patient on any treatment for anemia, what is the urgency, as I said, can it be delayed? Is it so urgent that you have to do it now? Can it be delayed for more than 1 month in following BMS and more than 6 months following DES implantation? Or are there any alternatives to surgical treatment? So the history when it comes to the stent, you need to know what kind of stent was being used. As I said, you need to know because you have to decide whether the patient can be taken up within a month or within 6 months. BMS or a drug-eluting stent. How many stents were placed? Single or multiple? Which coronaries were stented? The left main, LAD, RCA or circumflex, or all of them, or none, or some of them? What is the position and placement of stent? Is it proximal, distal, overlapping, bifurcation, or ostial? What is the timing? Is it recent, within 3 months, within 6 months, within 6 weeks, within a year, within more than a year? Are there any residual blocks? Because some of the cardiologists only do culprit vessel, they handle only culprit vessels. So are there any residual blocks? Or is there any history of stent thrombosis? Is the patient on monotherapy or, polytherapy with dual antiplatelet therapy? Or if the patient is on dual antiplatelet therapy with heparin? So all this question also has to be asked. Or whether the recommended duration of treatment is over, recently started. Is there any resistance? Is there any aspirin resistance? Because the resistance can be found out by doing platelet tests, aggregation tests, etc. Is there any cessation of therapy, whether clopidogrel was stopped 5 days before and whether prasugrel was stopped 7 days before, or is the patient on bridging therapy? All these questions have to be asked, and a combined ischemic risk based on all the history which we just elicited has to be taken. Now, perioperative management of a patient with coronary stent on dual antiplatelet therapy has remained a double-edged sword. Doomed if you take antiplatelet therapy wherein patient can have excessive bleeding. And doomed if you stopped dual antiplatelet therapy wherein patient can have a sudden death due to myocardial infarction. There is a lot of variation in practice. Some of them, stop 7 days before, some of them 5 days before, some of them 2 days before. We should not be doing that. We have our guidelines in place now. The intensivist usually is not in the picture during the most vulnerable period when the patient can develop stent thrombosis, that is about 24 to 48 hours. The patient is shifted to the room and sometimes even shifted home. So this is the time when the patient can develop STT changes and a devastating MI and death can occur in these patients. And you have to have a multidisciplinary approach. And of course, we as anesthetists, we are torn between two sides where the surgeons are saying no dual antiplatelet therapy, where the cardiologist is saying, yes, we need to give antiplatelet therapy. So now we are torn between the two, and there is so much of conflict of interest. So most often the stent thrombosis occurs, as I said, within 48 hours after surgery. If the dual antiplatelet therapy is stopped for more than 7 days, you can have catastrophic complication. That about 90 folds. That is the reason don't stop clopidogrel beyond 5 days. With safe interruption, with continuation of aspirin, the mean thrombotic event is much reduced. So what about bleeding? If the patient is only on aspirin, the bleeding will be about 2.5 to 20 times more than normal. Aspirin and clopidogrel, if the patient is continued on that, it will be up to 30 to 50% more. Remember, platelet infusion, you touch a platelet infusion only if there is catastrophic bleeding and you're not able to manage, and no proven value of aprotinin or recombinant factor 7A to treat bleeding, and it should not be used. So, as I said, the optimal delay, I'm repeating again, more than 4 weeks after BMS, more than 6 months after death, and more than 24 months if complicated lesions are there and if the patient has had an off-label use of stents. Coming to the algorithm for patients with bare metallic stents presenting for non-cardiac surgery. So let us look at two instances where the patient comes with less than 4 weeks after the stent placement or more than 4 weeks after stent placement. If the patient has come more than 4 weeks, stop clopidogrel 5 days before and continue aspirin throughout surgery if possible. If it is an elective surgery and if it is less than 4 weeks, please postpone the surgery until 3 months until 3 months. If it is urgent, can clopidogrel and aspirin be continued in the perioperative period? Is it a endoscopy? Is it just peripheral surgery? Yes, you can continue. Then proceed. If you cannot continue and if you feel you have to stop, then you at least can aspirin be continued? Yes, then proceed. If you say no, then consider bridge therapy for this patient. Now coming to the algorithm for patients with drug-eluting stent presenting for non-cardiac surgery. If it is an emergency surgery, life-threatening emergency, proceed with the surgery. In that case, have a multidisciplinary team in loop. High-risk patients be referred to centers where the most minimally invasive therapies such as laparoscopy or robot-assisted procedures or new generation lasers are available because bleeding will be much less in these patients. Blood products and platelet transfusions should be kept ready in these patients. And if it is placed more than 6 months ago, assess the risk of bleeding. If it is low, continue with the DAPT and proceed for surgery. If it is medium and if it is less than 6 months, continue with DAPT, proceed for surgery. If the length of DAPT is more than 6 months, stop clopidogrel, continue low-dose aspirin, assess risk of thrombosis. If it is low, proceed for surgery. If it is for high, if the risk of thrombosis is high, go for a bridging therapy. If the risk of bleeding is high, then you stop you have to stop DAPT because the patient is going to bleed to death. Assess the risk of thrombosis. If it is low, proceed. If it is high, bridging therapy. So basically, if the risk of thrombosis is high and if the bleeding risk is high, you please go for a bridging therapy. And elective surgery, please don't allow less than 6 months. So the bridging protocol with Cangrelor is like this. 7 days before the surgery, stop prasugrel. 5 days before surgery, stop clopidogrel. 72 hours, that is 3 days before surgery, start Cangrelor at 0.75 microgram per kilogram per minute. Okay. And within 6 hours before the surgery, stop the Cangrelor infusion. Go ahead with the surgery. And by about 1 to 6 hours, depending upon what's the bleeding, you can start the Cangrelor and start clopidogrel, a loading dose of 300 to 600 milligrams orally, depending upon the patient. If you're using tirofibin or eptifibatide, similarly, same thing with prasugrel and clopidogrel, stop 7 or 5 days before, 72 hours before, start tirofibin or eptifibatide. Eptifibatide is 2 microgram per kilogram per minute. Again, stop about 4 to 6 hours before surgery. Go ahead with the surgery, and by 4 to 6 hours, please restart. So, there are few reversal agents for anticoagulation in case there is excessive bleeding, but it is better not to use any of them because only if major bleeding occurs, you can think about using factor concentrates like prothrombin complex concentrate or idarucinab, which is a dabigatran, antagonist, or andexanet alpha, which is a factor 10A antagonist. So to summarize, you need to have a cardiology consultation. If a non-cardiac operation is contemplated during the vulnerable period of diminished stent endothelialization, the risk of bleeding from the operation must be weighed against the risk of stent thrombosis. Maintain the dual antiplatelet therapy if the risk of bleeding from the minor surgical procedures like dental extraction, cystoscopy, etc. is small. If clopidogrel cannot be continued, all effort should be made to continue aspirin. And if aspirin is contraindicated, as in surgeries of close space like intracranial middle ear surgeries, or if there is high risk of bleeding from the surgical site, antiplatelet agent might have to be stopped. Restart APT as early as possible. Remember, heparin, if you're using without antiplatelet therapy, can cause rebound and stent thrombosis. So don't use heparin alone. Platelet transfusion can be given 4 hours after stopping clopidogrel. Transfused platelets is not affected by residual clopidogrel or its metabolite. So bridging therapy, as I said, can be done with Cangrelor, Ticagrelor, or tirofibin. So the half-life of tirofibin infusion is just about like 2 hours. And Cangrelor, Ticagrelor is reversible. It's got a rapid onset. Half-life is hardly 5 minutes. And the reversal of platelet activity occurs within 1 hour. Well, we are dealing with a coronary patient. So when you're doing your non-cardiac, it has to be a tight hemodynamic control to avoid shear stress and disruption of plaque. Beta blockers useful for hemodynamic control and decrease the sympathetic outflow and platelet activation. Vigilance in observing for signs of ST elevation should be there. So assess the bleeding, have a large bore IV cannula in place. Packed RBCs should be kept ready. As I said, platelet infusion only if things are getting out of hand and life-threatening. Transfused platelets can render the patient hypercoagulable. That is the reason we don't want to give platelets intraop. And hyperthrombotic. The thrombogenic surface of the stents may attract and activate the donor platelets to an even greater extent, and you can have stent thrombosis. So what happens when the patient develops an ST elevation? So give heparin, bivalirudin. If the patient has gone into a shock, you can start inotropic support. Thrombolysis is prohibitive. You should not do that. Quickly take the patient to a cath lab if there is an index of suspicion. Remember, keep your defibrillator and IABP ready. What about patients who present for regional anesthesia? Dual antiplatelet therapy is regarded as an absolute contraindication to spinal and epidural and therefore need to be stopped at least 7 days before neuraxial intervention. If you're thinking of spinal anesthesia, that is definitely better than epidural. Single shot spinal is better than placing even catheters in the epidural space. Small gauge needles are safer. Avoid multiple puncture. And if there is a bloody tap, abandon the technique. Aspirin alone does not appear to increase the risk of neuraxial hematoma and does not appear to interfere with the performance of neuraxial blockade. Stop the tirofiban eptifibatide preferably 8 hours before the neuraxial blockade. I said 6 hours, but preferably 8 hours. Concurrent use of UFH or low molecular weight heparin, as I said, increases the risk of bleeding and neuraxial hematoma. So, dual antiplatelet therapy imposes extra care in siting of intravascular catheters, and it should be in areas where compression is possible. Ultrasound guided central venous cannulation is most appropriate. Can you please stop it? Superficial areas where compression is possible should be done. So nerve blocks should be ultrasound guided and it should be on superficial areas. If PCI intervention is needed in the postoperative period, catheter removal is recommended before the PCI and therapeutic anticoagulation. If PCI intervention is needed in the postoperative period up to 48 hours when BAPT is already reinstituted, catheter removal is not recommended before the PCI. So if the patient is on tirofiban, these ultra-short-acting agents, ASTRA guidelines recommend removal of an epidural catheter 1 to 2 hours before before starting the tirofiban or eptifibatide. Well, those who have clopidogrel and aspirin resistance, you have to do platelet function monitoring. Or if the patient has come for high-risk surgeries with excessive bleeding, or neuraxial blockade is to be done in an emergency, you have to do platelet function monitoring. PT, PT, APTT has to be done. Optical light transmission platelet aggregometry is the gold standard to know the platelet aggregation. Of course, we can do thromboelastography and other percentage aggregation with the platelet works analyzer, which is a point of care test. Plasma drug concentration of both aspirin and clopidogrel do not correlate with their pharmacodynamic effects, as both the drugs have short half-life but a long duration of action. And if you have to take sides, the balance should be tilted towards avoiding thrombotic complications as to avoiding bleeding complication. Remember that. We don't want the patient to die of coronary thrombosis. A strong communication between the anesthetist, surgeons, cardiologist, and intensivist is mandatory. Awareness, prevention, and early recognition and treatment of complications will always improve outcome in these patients in whom stents are being placed and who are presenting for non-cardiac surgery. Thank you very much.
Thanks a lot, ma'am. Such a wonderful lecture. We've covered all the aspects of a patient coming with a stent. We have few questions, ma'am. The first one is on the stopping guidelines for ticagrelor, ma'am.
On stopping?
Guidelines for the ticagrelor.
Okay, As I said, see, the guidelines are saying 6 hours, but then it is better to stop 8 hours before.
Okay. And can we use tranexamic acid in the perioperative?
No, that's why I said it's not going to help.
Okay. Are there any indications for platelet transfusion during surgery when the patient has a BAPT?
As I said, it is going to incite, coronary, the thrombotic potential if you give platelet transfusion.
Yes.
So only if you cannot avoid, only then you go for a platelet transfusion. Please avoid as much as possible. After you have postoperatively, when things are all fine, at that point of time, you can give it slowly. But then, as far as possible, we want to avoid a platelet transfusion. That is why we are doing all this, stopping, restarting. All this we are doing only because we don't want to touch the platelets.
Yes, ma'am. The take-home message is really impressive. It is to tilt the balance towards the preventing the thrombosis rather than the bleeding process. That is a very important point, ma'am.
Yeah. If you have to take sides, then you better take sides on preventing thrombosis.
Definitely, ma'am. Naresh sir has asked, what are the guidelines for obstetric patients coming for emergency LSCS? Is the same guidelines apply to them also?
Guidelines don't change. Yes, if it is an emergency LSCS, now we are not thinking of regional in these patients. It's an emergency. And if you have not stopped the dual antiplatelet therapy, right, then yes, we are not looking at regional anesthesia in these patients.
Thank you very much, ma'am. It was a wonderful lecture. And I would also like to add one or two things which I have seen in this few days, ma'am. People, when the cardiologist advises a CABG and the patients ask for a stent and the cardiologist goes for a stenting that is more than 2 or 3 on a bifurcation or a CTO, definitely these patients have higher incidence of perioperative events than patients.
Yeah, I said that actually.
Yes, ma'am.
These are the patients who, these are off-label use. So any patient coming with multiple stenting, long stents, bifurcation stents, ostial stents, small diameter coronaries, all of them will need longer antiplatelet therapy. As I said, 2 years at least.
Thank you very much, ma'am. In your busy schedule, you have given us time to enlighten us in this though it looks simple, it's a big gray area, ma'am. Thank you very much, ma'am.
Thank you, madam. You are a busy schedule. You have given a very tailor-made topic. To the point. I am very much impressed by your take-home message. You have to think towards thrombosis rather than bleeding. Very nice message you have conveyed. Thank you so much, madam.
Thank you so much.
Yes, Professor.
Next, I welcome Dr. BALAJI ASEGAONKAR sir to talk about perioperative devices. BALAJI sir he's the founder director of Ozone Group of Anesthesia and Critical Care. You all know he is the famous author of the Handbook of Practical Approach to ABG. He's been in active anesthesia practice for the past 22 years. He has worked at Hinduja Hospital and he has done his cardiac anesthesia from Ruby Hall Hospital in Pune. And he has been practicing anesthesia with various aspects like cardiac anesthesia, neurosurgery, anesthesia, heart transplant, robotic surgeries. Presently, he is the president-elect of Maharashtra State ISA, and he's been in Maharashtra State ISA active member for the past 11 years. And not only this academic and work side, he has also had immense social contribution. He has had a lot of palliative care services going under him. He has launched Parkinson's support group, post-COVID care rehabilitation, and elder abuse prevention groups also. So we are eager to hear from you, sir. Welcome, sir.
Good morning. At the outset, I must thank. Should I start?
Yes, sir.
At the outset, I must thank Professor Edward sir for allowing me to come here. My respected Indrani madam is there, even Dr. SIVAPRASATH. And it was a very interesting and practical discussion in our previous talk. Now I'm going to talk about anesthesia management of patient with permanent pacemaker. Now, these are the 7 wonders. And what are they doing in this presentation? This Taj Mahal or this Great Wall of China or Great Pyramid of Giza, which is Giza, which is built almost 4,000 years. We call all these are the wonders of the world. But if you ask me what are the wonders in medicines which saves maximum lives, and they are, one is rehydration therapy. Invention of these wonders, one is rehydration therapy, other is intubation, and the topic which today we are going to talk is about a pacemaker. These are the wonders of medicine which have saved maximum lives for the mankind. Now, the objective or the aim of my topic will be to review a basic pacemaker terminology and function, whatever is required for anesthesiologist, discuss the pre-op evaluation of patient with a pacemaker. We will also discuss intraoperative management of a patient with a pacemaker, and we will review about implantable cardiac defibrillator. Now, pacemaker is basically provides electrical stimuli to cause cardiac contraction when intrinsic activity of the intrinsic cardiac activity is inappropriate, slow, or absent to maintain the adequate cardiac output. Now, this is the basic of any pacemaker. Apart from that, it can sense intrinsic cardiac electrical potential, and it will deliver only needed on SOS basis. This is another function of the pacemaker. Now, if you see on historical perspective, this was a pacemaker built or first invented. It was a huge pacemaker in 1950, and real journey started from here. It was a very basic kind of pacemaker at that time, and person has to carry with him this kind of huge box wherever he is going. Later on, its size decreased. There was modernization in the pacemaker, and in 1958, actually, we got a first fully implantable pacemaker, which was placed under subcutaneously. Subsequently, the development was rapid, and in 2000 onwards, we were getting such kind of small pacemakers. But let me tell you, this development is on a very fast track, and now we are with this kind of pacemaker, what we call it as a micra. It is 1 inch long. It is the almost 90% times smaller than this. It has to be implanted in a heart, and it will do all the functions of the pacemaker, and very soon it will be operated through a mobile app. This kind of innovations is going on in this pacemaker, and we are in a very near future, we will get this kind of pacemaker where even battery is not needed, batteryless device, which will harvest cardiac motion to power the pacing circuit. So pacemaker technology is developing very rapidly. Now, as an anesthesiologist, whenever such a patient come to us, we have got so many questions about patient, about pacemaker, or about intraoperative management that we are today going to discuss. Now, basically, pacemaker has got 3 components. One is a pulse generator, which generate all the rhythm. Another, that generated rhythm conveyed to the heart through this electric wire. And there is a contact point or electrode, which communicates with the heart through this pulse generator. Now, there are 2 types of pacing modes or methods. One is transvenous, which maximally we are using maybe for temporary or even for permanent pacing purposes. We put through maybe by venous axis, we put electrodes into the heart and we try to govern them from outside. This is the transvenous pacing. But in cardiac surgery, we also place epicardial pacing, where we directly put electrodes over the heart and we govern them from the outside. Now, what are the indications of pacemaker? If you want to simplify the indicators, first is bradycardia support. Any patient who has got heart requires a bradycardia support, whatever may be the reason, maybe complete heart block, maybe AV, high degree AV block. For that support, we put a pacemaker. Now, what is rate responsive pacemaker? Rate responsive pacemaker, as you know, suppose if you pace the heart at fixed rate of 60, 70, but suppose patient's requirement is increased, maybe due to exercise, maybe due to emotional excitement, maybe due to shivering or fever. Can pacemaker increase its rate? Yes. When pacemaker has got this capacity to increase its rate, we call it as a rate responsive pacemaker. Another invention or another addition to the pacemaker function was the invention of AICD, cardiac resynchronization therapy, as well as artificial implanted cardioverter defibrillator, about which we are going to talk. So this is a cartoon where this gentleman is saying, feel my pacemaker if you don't believe me. This is a rate responsiveness of the pacemaker. Now, pacemaker, as I already stated, this is pulse generator. These are the wires and these are the electrodes. And this is how it placed. On subcutaneously, invariably, it is in the place below the skin or below muscle. It is connected to the leads. And that pulse generator has got a lithium iodide type of battery, which is usually lasts for 5 to 10 years. And over a period of time, that output voltage gradually decreases, but sudden battery failure is very unlikely in any kind of pacemaker. Now, this electronic circuit, it determines the function of the pacemaker itself. And this, whatever electronic system or whatever pacemaker system is there, it has got some standard nomenclature, which we are going to see in a next slide. So I already told you pacemaker has got two functions. One is sense the intrinsic cardiac activity and other is to electrically stimulate the heart. Now, British physiological and electrophysiological group, they have shown a nomenclature to the pacemaker system. Suppose we put pacemaker VVI or DDD, what does it exactly means? The first letter in this description is always chamber paced. Second letter in this description is chamber sensed. And third letter in this letter is what is the response, whether it is inhibitory, is it a trigger, is it a dual response? And all fourth and fifth letter are for advanced kind of pacemaker, whether it is a programmable, can it deliver shock? All these letters are there. In this way, whenever pacemaker is there and it will have a certain name, if you read this name if you read this name carefully, you yourself can draw the conclusion. Means what are the whether which chambers are paced, whether these chambers are sensed or not, and how is the response. For example, there is a VVI pacemaker inserted. Means ventricle is paced, ventricle is sensed, and response will be inhibitory. Now, pacemaker lead system is nothing but the endocardial leads placed via central axis into the right ventricle or atria, and they are fixed to the endocardium. It may be a bipolar or unipolar. Bipolar means anode and cathode will be on the same end, maybe with some distance difference, while in unipolar lead, only cathode is there, and through skin, anode means positive charge will carry out through the skin. Another important invention is we can bury these leads into the ventricle. Cardiologist can screw these leads or electrodes into the ventricle so that it will require a minimum current to stimulate the heart. Now, what are the types of devices available? Whenever there is a problem with conduction system only, permanent pacemaker. In India, 90% of the times, whatever pacemaker we get, these are the permanent pacemaker. In less than 10% of the time, for certain advanced features of the pacemaker, like treating a life-threatening arrhythmia, what we call as a artificial implantable cardioverter defibrillator, that can be incorporated into the pacemaker. Another important big area now coming patient, those patients who are dilated cardiomyopathy or patient who require or failure treatment, they can be treated with a pacemaker, what we call as a cardiac resynchronization therapy. When you add defibrillator into it, we call as cardiac resynchronization therapy with defibrillator. For this type of broadly, this all devices divided into these three categories. Now, for treating heart failure, many times what happens, patient is symptomatically in heart failure. His ejection fraction is 20%. He is on optimum medical management, but still there is a dyssynchrony between his contractility of atrium, ventricle. In that scenario, what we want to optimize his cardiac output. Now, how it can be done? By pacing the patient with 3 leads. I mean, atrium is also placed, right ventricle is also placed, and left ventricle is also placed. And electrically, their contraction is managed so that cardiac output can be increased. This is what we call as a cardiac resynchronization therapy. Now, suppose the patient with pacemaker come to us for pre-op evaluation. Now, as an anesthesiologist, what I must know, I must see his all previous paper. What was the indication for which patient received pacemaker? What was the set heart rate of that pacemaker? Another important, is patient pacing dependent or not? This is a very, very important question for us or as an anesthesiologist, because we have to do certain precautions or certain preparation in the OR when we answer this question, which I'm going to talk about in our next slides. Now, when you call patient to be pacing dependent, suppose 40% of his heart, his QRS complexes are paced, then we call it as a patient is pacing dependent. Now, there are 2 modes by which patient can be paced. One is demand mode and other is fixed mode. Demand modes means patient intermittently undergoes bradycardia episode. His heart rate normal may be 70, but it is occurring 30 in between. At that time, when demand arises, if pacemaker providing that support, we call it as a demand. Another is fixed mode. Pacemaker won't sense anything. It will go on fixed number 70, 80, go on pacing the heart rhythm. That we call as a fixed type of pacing. Now, see the location and duration of that pulse generation. Where it is located, this is very important when you want to use a cautery for that pacemaker. And how much was the duration of? Why you want to ask duration? To gauge about the battery life of that patient. That is why, as an anesthesiologist, you need to ask the duration. Now, what is the type and make? This is more concerned to us. Rather, cardiologist is more concerned with this. What are the type and make of this pacemaker? And all these details you can get through the company, that old paper, discharge card, or invariably company provide them some card. All this detailed information is there. Always seek cardiologist opinion about the functioning of the pacemaker and its present status. Now, is only evaluating pacemaker adequate for anesthesiologist? No, we has to evaluate the patient for associated comorbidity. Let me tell you, the patient who has got a pacemaker, there is high chance, 50% chance that patient will have a coronary artery disease. 20 to 30% chance that patient will have hypertension, diabetes. Then always ask for symptoms like dizziness, syncope, congestive cardiac failure, blurring of vision, sudden vertigo, because this may give you a clue that pacemaker might be, its function is not good. Then always note down the patient's heart rate, which is actually present, and whatever the heart rate with which pacemaker is pacing the patients. Always try to ask for the effort tolerance. But in a patient with a pacemaker with a fixed heart rate, it may happen that due to this fixed heart rate, patient may feel breathless when demand arises. This is only in fixed heart rate pacing. This is not rate sensitive pacing. Then always, apart from your biochemical investigation, see for ECG, X-ray, electrolyte, and echo. On ECG, you will be able to identify such kinds of spikes. These are the spikes generated by a pacemaker. These are the atrioventricular sequential pacing. 2 spikes are generated. While here it's only single chamber paced. So only 1 spike is generated. Always see X-ray. Preferably take a deep penetrating view of the X-ray. Why? What is meant by deep penetrating view? When you are able to visualize the spine on an X-ray, we call it as a deep penetrating view. On X-ray, you can get a lot of information about pacemaker. For example, in this X-ray, this is a sequential pacing. Atrial lead is there, ventricular lead is there, and it is a dual chamber sequential pacing has been done. In this X-ray, there is single chamber pacing, but anti-tachycardia function, that is defibrillator. If you see these two coils, these are for giving a shock. This is cardiac synchronization therapy. See, this is atrial lead, this is a ventricular lead, and one lead in coronary sinus. So that all this will, there is a cardio dilated heart, means it is a cardiac resynchronization therapy. This is again cardiac resynchronization therapy with defibrillator attached. So X-ray gives us immense information. Now, as far as anesthesia management is concerned, all these cases has to be done at tertiary or equivalent care hospital where cath lab facility is available, where cardiologist available, where ICU is available, good quality operation theater with backup for putting accessing central line, good quality monitor. So all these are very high risk cases, should be done and must be done at a tertiary care hospital. Always monitor ECG, SpO2 and IBP, and preferably arterial line. Why? Because we want to monitor the mechanical function of the heart. Now, how to monitor the mechanical function of the heart? One is electric function of the heart we are monitoring with ECG. But the mechanical function of the heart, whether contraction is actually happening, whether adequate cardiac output is actually generated, that one can monitor with the presence of arterial line. Or another way is for smaller cases, plethysmograph. It also indirectly tells us that about the cardiac mechanical function of the heart. On ECG, when you are monitoring ECG, there is one pacing mode. If you make it on, it will show the pacing spike with each ECG. That is, if heart is paced by a pacemaker, it will be shown on a monitor. Always keep defibrillator ready because there are high chance patient can suffer from various kinds of arrhythmia, and external transvenous pacing ready. In certain cases, when you are doubtful about the pacemaker, its function, or its you should have access to the central vein. You should take either femoral or IJV cannulation. And in certain situations nowadays, external pacemakers are also available. Just apply this. In drastic situation, you can take the help of this kind of pacing. I already told you about monitoring the electrical and mechanical function of the heart. Now, suppose you want to insert a CVP or pulmonary artery. This is a very high risk because it itself is arrhythmogenic. Secondly, it can disturb the lead pathway, which leads are going through the same pathway, especially PA line or Swan-Ganz. It's very difficult. Another, if at all you want to put the CVP, don't put that guide wire too much. Don't put the length of CVP too much. That precautions, you have to be very gentle while putting a central venous access. It is said that certain anesthetic agents, maybe like scoline, ketamine, or whatever myoclonic movements occurs, that will be sensed as a pacemaker and it will change its activity. This is common, but for that matter, you have to put patient on a asynchronous mode. I'm going to talk about it in a next slide. Now, in these patients, fluid management is a bit difficult because we don't have a normal response like tachycardia to a shock patient. So one has to be extremely cautious when you are managing a patient with a fixed heart rate during intraoperative period. Mechanical ventilation with IPPV, with lot of PEEP, can cause dislodgement of leads. So one has to be careful when you are mechanically ventilating. As far as possible, avoid shivering and myoclonic potentials and all that. Now, magnet use. Previously, it is said that whenever, suppose such patient comes in emergency with some rate sensitive pacemaker, you put a magnet and naturally it will put that pacemaker on a asynchronous mode. But now this is controversial. Nowadays, pacemakers are coming with a lot of sophistication, and just using magnet will not revert them on a asynchronous mode. So nowadays, magnet use is very much restricted. the most important take-home message or the point that one must remember is always deactivate the rate responsive mode of the pacemaker. Always put it on a asynchronous mode. Asynchronous mode means pacemaker pace the patient with certain fixed heart rate and it will not sense anything, so that even your use of cautery, even whatever the problems that you will face, that will not be sensed by the pacemaker, and patient will have a certain fixed heart rate throughout the intraoperative period. Now, one also must know what are the factors that can affect the pacing threshold. Why, as an anesthesiologist, I should know? Because these factors are very, very common in perioperative period, like acidosis, hypothermia. Suppose there occurs a severe hypothermia, that pacing threshold is increased. Means suppose patient is paced with a 5 millivolt, but that threshold may went to 8 millivolt. In that case, if you are pacing a patient with 5 millivolt and there occurs a hypothermia, patient may not get paced, and you will see, you might conclude that pacemaker is not functioning properly. So one must know what are the factors that increase the pacing threshold, like hypothyroidism, hypothermia, acidosis, all that. Similarly, stress, increased catecholamine secretions, use of sympathomimetic drugs can decrease the pacing threshold. Now, this is a very important aspect of my talk, that is pacemaker is very sensitive to direct or indirect electromagnetic interference. For example, can pacemaker patient go for an MRI? As if pacemaker is not MRI resistant or safe, patient cannot go MRI. Can you use cautery? I'm going to talk about cautery in the next subsequent slide. But if patient is on a sensing mode, all these are not allowed. So nowadays, this kind of Medtronics has come up with this Azura and Ativasta, all this kind of MRI sure scan. If these pacemakers are there implanted into a patient, then only MRI can be allowed. Otherwise, if you allow, there are so many incidences or case reports where MRI done to a pacemaker patients, and there are many mishaps has already been occurred. Similarly, use of orthoscope, lithotripter, if that sensing function is blocked, all these they will not able to disrupt the pacing functions. Now, as far as electrocautery is concerned, there are more than 700 adverse events reported in history that use of cautery has even caused a death in a patient with a pacemaker. Now, how to go for it? Use bipolar cautery as much as possible, because circuit is completed at this level only. If at all you want to use unipolar cautery, ground plate should be close to the operative field. Suppose you are doing hernia surgery, just put ground plate below the buttock so that circuit will be completed. So unipolar cautery should be used. Pacemaker should always put pacemaker on a asynchronous mode. How to put it? We have to call that a pacemaker company person inside the OT, or a 1 day prior to, or in the morning on the day of surgery, and put that pacemaker in asynchronous mode. And cautery should be used. Initially, when you start using cautery, always check with short burst whether it is causing pauses, whether it is interfering with a mechanical function of the heart. Then and then only you should start using cautery. One has to be extremely careful about. Avoid use cautery within 15 centimeter of pacemaker. These are for unipolar. And nowadays, maximally, we are using a bipolar kind of cauteries. Temporary pacemaker should always be kept ready. Any mishap, if pacemaker is not functioning, how will you able to increase the heart rate of the patient? These drugs like isoprenaline, atropine, you should be kept ready, but they may not be effective. So temporary pacemaker must be always kept ready. Always remember that one must post-operative recheck the pacemaker functioning, call that company people, take 12 lead ECG, always ensure that patient electrical as well as mechanical function of the heart is adequate whenever you are shifting that patient into the post-op room. So the take-home message is always evaluate patient and pacemaker in detail, put pacemaker on an asynchronous mode, and disable all anti-tachycardia function whenever such patients is come for any type of surgery. Monitor effective cardiac output, means monitor the mechanical function of the heart, and always keep the contingency plan ready. So I always suppose that think that anesthesiologist is a pacemaker of operation theater, as he synchronizes all asynchronous patient, surgeon, and staff. Thank you very much.
That was really nice, sir. Really, we are the pacemaker of operation theater, really, sir. It was a nice lecture. Very difficult topic. Sometimes we get confused on what to do. Once we get a patient with the pacemaker, we are in a crossroad, and we are always in attention in the perioperative period. Also, what will happen next? Will it fire and create some other arrhythmia, or will it stop firing? So it's really difficult to manage the perioperative period. This lecture, I think, is very clear about it. Well, there is one question on how to defibrillate a patient who has a pacemaker but without an ICD function.
Yes, if you put, one has to first of all put it in a asynchronous mode. Naturally, you probably have done it during the perioperative period. Secondly, the pad placement for defibrillation should be away from the pulse generator. Ideally, it should be around 15 centimeter away. So one can apply nowadays, disposable pads are available. So you can apply one pad on the back of the chest of the patient and another called below the sternum at apex, where apex bit is there on the mid axillary line. It will be naturally almost 15 centimeter or more than 10 centimeter. In that case, you can defibrillate the patient. But let me tell you, if you defibrillate the patient, the original functioning of the pacemaker might get changed. There will be a activation of reed circuit, what we call inside the pacemaker. So one has to, when operation is over, one has to reprogram that pacemaker. That is very, very important.
There's one question Edward sir has asked to again tell about the asynchronization for the sake of PG, sir.
Yeah, asynchronization. Asynchronized pacing means suppose we want to pace a heart with a fixed rate of 80. Now we don't want heart function, means whatever is basic heart rate, 60, 70, we don't want anything sensing from the pacemaker. That sensing function of the pacemaker, if you make it off, it will make asynchronous pacing, means whatever heart condition may be, it will pace at a certain fixed heart rate. That is asynchronous pacing.
Yes, sir. See one more question. Question from me, sir. Suppose we know the mode of the pacemaker, if it's like DDD, VVV, and it does that only that function. Is there any change in the perioperative management if we know the actual mode of the pacemaker, or it should be always taken into the asynchronous mode when we take the patient to surgery?
Certain surgeries, like suppose endoscopy is there, colonoscopy is there, where there is a cataract surgery is there, less chances of use of cautery, then there is no need to disable this rate sensitive pacing. But when there is a major surgery, when you was to use the extensive cautery, or there is suppose any electromechanical signals are going to be there during the surgery, at that time, you should always put the patient on a asynchronous mode. Recently, we have done one CABG on a permanent pacemaker. We call that person, we put on asynchronous mode, we increase the heart rate, and we done the CABG.
And your thing on how the voltage needed to pace changes with hypothermia was really interesting, sir. Even I have not even thought of it. was very nice, sir. All the conditions which change the way a pacemaker behaves in the perioperative period, I have not seen it. Thank you very much, sir.
Thank you, sir.
Okay, so I think all the questions are answered, sir. Yes, sir. I'll just check that. In asynchronous mode, should the rate be kept more or less than the patient's heart rate?
If you put the patient on asynchronous mode, particularly in perioperative period, I feel rate should be put on between 80 to 100. It should be put on 80 to 100 because many times this demand is increased.
Yes, sir. Edward, sir.
Sir, if there is no more questions, thank you very much, sir, for a wonderful presentation and the easy way to understand the pacemakers for the postgraduates and the consultant. Thank you so much, Balaji, sir. Thank you, Sir Professor, sir, for coordinating today's session. Today's topics, both topics were excellent and the coordination is also good. At this juncture, I thank the sponsor, Akrula, and our co-telecast, that is Anesthesia TV, and also the telecast partner, that is A1 Logics. Thank you, one and all. We will meet next week, next month with an interesting topic in the pain management. Thank you.
Thank you, sir. We appreciate our activities. Thank you very much.
Thank you,
Balaji, sir.
Yes.
Thank you, sir.
Yes.
Thanks to all the participants.